Very excited for our next speaker. Very honored to have Aneesh Chopra, who is the former CTO of the White House and is now president of CareJourney, and he's going to talk about generative AI in healthcare. Aneesh?
All right, here we go. Hi, everybody. Come on in, come on in, come on in. Let's go have fun. Excited. Thank you so much for taking the time. Last slide of the day. You had a great couple days, a lot of inspiring speakers, and I'm grateful. Let's get to know each other briefly. How many of you are currently in healthcare IT? Just by show of hands. How many of you are interested in joining the health IT movement, given your interests and background? Good. Okay, we need you. And how many of you are, generally speaking, AI focused at the moment? In other words, the marriage of, okay, everybody. All right. Let me begin with a little bit of history and context. First and foremost, it's been great to see the IIT alumni community thrive. During my time in the Obama administration, I spent a good deal of time with many of you, and it's been great to have so many within the community who want to step up and participate in solving big problems. One of the powerful moments that we're in with AI is that it can be put to a whole number of uses. Early applications can certainly be in the social media, commercial internet space, but the application of AI, and very specifically generative AI, in health, education, energy, these are the areas that I think we're going to see some of the greatest areas of rapid advancement. So my job today, as we wrap the session, is to give you a window on why I'm bullish that this is the AI spring we've been waiting for, and hopefully give you a bit of a roadmap as to where you might bring your technology business into the sector, because the sector is desperately seeking productivity gains. Now, for a little bit of history, in the Obama administration, as you recall, we made sizable investments towards the digitization of healthcare. We put nearly $30 billion to underwrite the deployment of electronic health records. Up until that time, maybe a quarter of the hospitals were on an electronic system, less than 10% of the physicians. A decade later, we've now reached nearly ubiquitous hospital electronic health records and well over 85% of physician practice digitization. So healthcare notoriously moves slowly, but in the last decade, we've had a hockey stick moment on the adoption of technology. However, for reasons I will explain, it's the one sector, to my understanding, in the global economy where this much infusion in technology resulted in lower productivity. Alan Greenspan famously said, just add water. If you bring technology to a workflow, you make it more productive. And a big reason why the US was moving to a new normal of consistently high productivity rates is that we had thoughtfully introduced technology in the enterprise. And so a big argument for digitization of healthcare was not just the safety and quality arguments, but also because we felt it would boost productivity and be a critical enabling ingredient to change the system so that we would get a bit more balance in the investments needed to keep our country healthy while reducing the overall burden on society. So a more with less objective, we felt needed investments in IT. My sense is that the productivity gains we hoped for a decade ago will materialize because we needed this last layer of capability to make sense of all of the complexity within the data systems in order to help people do their jobs better, faster, cheaper. So in many ways, this is the last step of a program that we thought was going to be self-contained and move us in that trajectory on its own. But for this technological advancement, I think we would not have been able to see the full benefit. So I'm going to stroll down memory lane and remind all of us, why does the American healthcare system cost Now it's about 18% of the gross domestic product and have a growth rate that appears to exceed overall inflation consistently year over year. Our power formula for change was largely the following. First, digitize, then liberate data. Change the financial incentives so that the use of that information to keep people healthier longer, to detect disease earlier, would drive behavior change. And that virtuous cycle, more incentives to reward health outcomes, more information liberated, circulating through the economy, we would make a much bigger dent. We launched Startup America during my time in the Obama years, and I remember a Stanford professor famously said, one clear way to find how startups thrive is when the rules of the road of a given industry are changing, incumbents move slower than the new entrants, and so that is the discontinuity that gives the outsized returns. We're in that moment in healthcare where we're shifting the incentives and the business model of healthcare, and the incumbents are taking a little bit longer to get there. So there is a window of opportunity for new entrants to make a difference. And so that's a little bit why we're bullish. Now, all of this is the good news. Let me tell you the bad news. The bad news is that while we've been a decade in the making, and I'll share all the good attributes of the decade in the making, we have not yet seen those attributes result in lower healthcare costs. In fact, employers today are finding double-digit increases in their healthcare. So this feels a little bit like, why are you saying such positive things? This is not my life. Well, let me walk you through what the positive things are, but acknowledge at this moment that we haven't seen the full weight and fruit. What have we had in the information liberation space? 3 key policy levers on our information. Number 1, we as individuals have the right to access our own health information, and now thanks to this digitization program, we have the right to access that health information through an application of our choice. My mom and dad are retired, they live in Florida. My mom now puts all of her health information into Apple Health and shares it with me so I can monitor her key statistics to help her manage her chronic conditions. We have those rights. In addition to the right to access our health information, we have the right to request prices. That's called to request a good faith estimate. And we have the right to kind of find providers that have higher quality so we can smartly choose where we want to go to get care. Now, I'll say these things as rights because they're enshrined in law, but I understand full well very few people know that they have these rights. If you go to the average doctor and say, I have the right to my health data, they're going to say, okay, I don't know what you mean. I have a fax machine, and do you have a fax number? Or I can give you a CD-ROM for your imaging studies. I don't know what else you're talking about, but it's like this analog world. Technically, they have the software to do these things, but most people don't know how to turn the features on. So this is a supply, sort of regulatory supply, but industry and market demand and use gap, acknowledging it. Once we asserted that the consumer can influence their information flow, the next step was how do we take that same information and share it with the person's doctor? Now that seems easy. How do I make sure that when a doctor is coming, that I'm going to go see a doctor, maybe before they see me, they might do some homework and find what other doctors know about my health status. These are complicated workflows. Should individuals opt in and say, I give you permission to go pull my medical records? Should that be an opt-out? Should I just say to the doctor, I'm going to prohibit you from searching my records, I'm going to remove myself from the health internet? How do parties make judgments to say that Dr. Smith legitimately needs to see patient Joe's records? And if I fraudulently asserted that I'm the new doctor, would that constitute a violation of that patient's privacy if I mistakenly sent their medical records to, essentially a Chinese hacker who chooses to sell it? So we have rights, the clinical rights to access health information. Doctors have rights to know if you've been admitted to the hospital so they can coordinate your care. But the implementation of those rights, similarly, is a bit gray. We're trying to chip away at ways to make that black and white, but it's not so easy. Okay, that looked different. Let me see if I can get back to my deck. Oh, did I lose it? Hey guys, can we get back to there you go, thank you. Let me go back. So the third element is that your health insurance companies and your doctors are starting to kind of coordinate to make sure that you're getting at full value of the health benefits you've paid for. But some of that involves the sharing of health information that's somewhat new. And so through contract negotiations, these parties can share information on our behalf. And that also is an area that's technically capable and live, but may not be operational in practice. The second part of open data is the fact that now for the first time, we can look up exactly how much money Medicare spends on every doctor in America. Now many of us have physicians in our family. This is somewhat uncomfortable. Up until the Obama administration, it was illegal to look up this kind of information. But now if you said, who was the highest paid doctor in the country, the Wall Street Journal for 1 year put up a database when we first released the data in the Obama administration. So Dr. Derek Kunimoto was the highest paid doctor. He got paid $11 million from Medicare. And now you might think that's a lot of patient visits because it's only maybe a couple $100 per visit. But it turns out that a big chunk of that money was that he would be basically paid for drugs that he would administer to help people keep their eyesight. Now, what you may not know is that there are several options available to doctors. There's a $50 injection and then a $3,500 injection. It kind of goes between the two. You can guess which one Dr. Kunimoto predominantly uses. The NIH says they're basically the same clinically, same outcomes. But one pays them more money in the form of a financial, they get a 6% wholesale overhead fee. And then if they can buy it at a discount, they could actually make upwards of 8 or 10% of that pass-through spend. So you can sort of see the financial incentives come into play. Now, where do we get to generative AI? I said at the beginning that in the Obama years, we declared that, as President Obama said, consumers have access to their own information and to the applications and services that can safely and accurately analyze it. Dr. Zach Kohane, an MIT professor / Harvard Medical School professor, he's kind of a joint, he submitted a proposal to DARPA on the idea of AI, but obviously a couple decades before we have the newest version of these capabilities. He proposed that we should give every American a guardian angel or a digital guardian angel that could be authorized to access all of our healthcare data streams, and that it would be interpreting those streams to guide us on each step of our journey. Now, you might want to go work for Suren's new company, but one idea would be who is due for a lab test or to make sure that their diabetes is under control or their blood pressure is under control. These guardian angels can say, oh, looks like you're veering off course, let's course correct. And companies like Suren's may help get people rerouted to the tests that they need to stay up to speed as to whether or not they're getting the care. By the way, these are the kinds of maintenance investments we need to make to keep us from going to the hospital during crisis because we hadn't taken care of our health. So these are critical opportunities. Peter Lee, as many of you have been following the AI revolution, Peter Lee is the head of research at Microsoft, and he's been living and breathing and dreaming with GPT-4 for the last year. He co-authored the AI revolution in medicine with Dr. Kohane, and he used to work at DARPA when I was in the White House, so we worked together on a number of projects, and he is brilliant. He said, as an example of what you can do with GPT-4, if I uploaded my doctor's lab results, even if it was a PDF, he asked the simple question, is there anything in my recent lab results that I should be worried about? And GPT-4 said the values suggest that you may have some form of anemia or iron overload disorder. It's not a diagnosis, but you might want to ask your doctor for further treatment. We're in the beginnings of this beautiful era where we can get the expert support we need and shift from search engine Dr. Google to a supercharged, personalized co-pilot to help us navigate the system. Now, I mentioned to you that this is very much the needed step to realize the productivity gains that we talked about in the early innings of the $30 billion program. You could see in the sort of widely cited graphic on the left, hospital services are the fastest growing and highest inflationary goods and services amongst any indexed to 2000. They've gotten more expensive over time, even though we've injected a sizable chunk of digitization. The great news is researchers have already begun recording when you apply generative AI in the context of decision support to workers, it really helps the bottom performers get dramatically better, more so than the best getting supersized. So you could see this graphic. BCG did a study with Harvard Business School, Karim Lakhani, who might have been a speaker actually, or if he hasn't been, he should be one at Penn IIT. And so he basically said, look, you can identify this as a rising tide lifting the bottom half of the boats in many ways. So this is an area that I believe was going to be a huge opportunity, but it's just the beginning. Current GPTs are trained on the internet. Much of healthcare data has not yet been used as a training input to a large language model. So as we think about a future where we get to the large language models with training safely and securely on longitudinal linked healthcare data, there's an interim step. And I believe that interim step will be about the unlocking of data sets, basically give everybody a data scientist. If I asked a hospital or I asked an insurance company, how many data scientists do you have on payroll? They may have a couple dozen, couple hundred. But imagine in a workforce of 100,000 people, everybody gets their personal data analyst. So to give you a window into that future, Ethan Mollick, a Penn professor, said, here's all the underlying data collected by the federal government on colleges. We have something called the college scorecard. Of course, if IIT were allowed to be compared in this way, it'd be even better to see what the relative rankings were. But for the moment, we're limited to US institutions. He said, here's the data table, and here's the underlying information. Construct a ratings engine to tell me who the best schools are, as best you can, and then run that rankings engine on the data set. And as you could see, it generated a methodology and executed it all by itself with MIT ranking at the top. I went to Hopkins, by the way, top 10, I'm very proud of it. Now, my role in many ways, and even to this day, is to try to get that public-private partnership right on responsible use. Health is not the same as applying AI to your photo collection to help identify your loved ones and to flag them or tag them. That's interesting, and if it hallucinates or gets it wrong, no big deal. But if we have those same errors in health, it could be life or death. So we've got to come up with a model that delivers on the promise of AI, in particular generative AI, by emphasizing its role in outcomes, but to develop a set of transparency and risk management provisions so that we all swim in the same lane. For example, if you email your doctor, today, more and more of those doctors are having a GPT draft the initial response, and then they look at it before hitting send. Should healthcare organizations watermark such messages with a footnote that says, this message was automatically generated and reviewed by your doctor? Would that increase trust? And if so, how do we scale that idea across the health system? Today, our regulations don't have anything to say about this. So I worked with about 30 organizations and the White House just a little bit over a month ago, and we announced a kind of public-private partnership where the industry agreed to adopt a set of transparency provisions to ensure the fairness, the accuracy, the validity, the effectiveness, and the safety of models, and to implement a set of risk management principles that could be a best practices model for others to see. We need to have this layer, this non-technical layer, coincide with the technical deployments in order to realize this potential. I've called this a digital Hippocratic oath for the 21st century, and you can see in survey after survey, will patients trust big tech to handle their health information? You can see in the graphic, dead last. They will trust their physician. So we'll start to see more physicians introducing these technologies to help people better navigate and ensure that they get the right care at the lowest possible cost. Let's save some room for questions, but I wanted to share with you a little bit of a window into the world of generative AI, and I thank you for your time at this very last session for Pan IIT. Thank you so much.
So if you have any questions, can you please come here? We have time for maybe a couple of questions. Otherwise, maybe you can talk to Aneesh outside. He'll probably stay for a few more minutes.
Absolutely. Thank you. Tell me your name.
Hi, I'm Shri Moisam, and I had a question for you because you mentioned the rights that we have as consumers.
Yep.
I believe you maybe alluded to the Transparency and Coverage Act as an example.
Oh, look at you, expert. I love it. Thank you.
My question is, the government may help us establish what rights we have, but what I find a little bit lacking is the quality of the information that we get back.
Absolutely.
So with the Transparency and Coverage Act, you know, we are supposed to be getting good faith estimates from our payers, our insurance companies, on what would we owe if we went to a specific provider for which service. But we as consumers don't know all the information of what services should we be looking for and how they reconcile with our claims.
This is a beautiful question. Thank you. Let me share the following. Yin yang, or serve volley, okay? Congress put that law into effect, but when the Centers for Medicare and Medicaid Services tried to write the rule, they needed a technical standard on how you request the good faith and what's expected in the response. Because the private sector did not reach consensus on a technical standard, that provision of the law has been frozen. We cannot issue regulations because there is no industry technical spec to digitally request the price and get back a response. So I am working in a program called projectclarity.health to voluntarily get technical firms to agree on what does it mean. So we're launching 300 good faith estimate definitions in the next 3 months, but it's voluntary. So we need public-private collaboration. We need more stakeholders to demand it, because right now Congress said we want it, but the administration can't execute absent the private sector reaching consensus. So that's a great point for almost everything in technology. Standards in the US have to be developed by industry consensus. We're not, in China, they could just say the Chinese government's gonna say it's this. In this country, we can't do that. We need to have industry consensus, even though Congress has mandated the process.
Hi, my name is Rich Altmaier, and you mentioned the data access problem. IBM Watson, I understand, failed being a physician assistant because hospitals said no access to data, period, even with the system deployed in the hospital. Is that overcome?
It has. The Cures Act in 2016 demanded open access to physicians in the hospitals, so it's not the IT that controls the data, but it's the doctor. So if the doctor wishes to have IBM Watson give it a second opinion, first of all, that product I think is toast, so probably be some new version of that, but let's assume there's something that's better, they have the right. The Cures Act now imposes a $1 million fine on IT companies that block access to the information that a doctor entered when they purchased the software. So if I bought the software, I have the right to take the data out and give it to a GPT of my choice.
So I hear that pharmas have zero interest in GPT because they are scared of getting sued. so they are just like, okay, if someone third party puts out a tool to educate the patient better about the medication and its side effects, good about it, but we don't care. So who cares about it?
So here's an interesting conundrum. Pharma, when they make a claim, have to back it up with evidence. So they cannot allow a GPT to make claims or hallucinate because they're liable. But to give you an example of the president's cancer moonshot, the National Cancer Institute is developing a series of APIs so that if I wanted to know if a loved one who's been diagnosed with cancer qualifies for a trial, then that information can be brought to my attention through a GPT. So there is an opportunity with democratization of information to be able to have an ecosystem navigate people, even though the FDA regulates what the pharma company says explicitly to the public. And I think we can well within the rules work to make sure that the underlying evidence of side effects or other problems can be fed back, so that if people were taking the medications, it's faster to learn that, oh my goodness, people of this type that take this medication have worse outcomes, and that we should have a feedback loop to make the regulatory process better. Last one.
Thank you. My name is Uday Nadkarni. I had a question about whether and how AI might be used or is currently being used.
Very little is being used right now, let's be clear. It's just getting started. This thing's a year old for generative AI, but keep
great,
going.
Because we can speculate now.
Yeah.
But to specifically detect and reduce fraud, like in Medicare or insurance, as well as try to reduce and eliminate inefficiencies in the market, like you pointed out about that $11 million doctor.
So this is
Can AI be used, like ML or something else?
100%. So you need financial incentives. Here's the mic. You need financial incentives to reward the detection of fraud or the closing of said gaps. So CMS has created these things called accountable care organizations. So now a primary care doctor gets access to the same information that the bureaucrats at CMS have been looking at with technology for years and not seeing anything. Now primary care doctors are saying, oh, if I can find the fraud in my population, I can lower the waste, and if I get lower costs for the same population from last year, I get a check from the government. So over $1 billion of checks have been written to primary care doctors for being a better identifier of inefficiencies. So that's why we felt that if you're gonna hug anyone to bring your generative AI product, that's why I've been telling Suren, hug an accountable care organization, because they will be aligned to rid out the waste because they get a percentage of that. And business models are emerging to say, I'll give you the technology for free, give me a portion of the check you will earn, and that will fund my development. And so that's, I think, a big opportunity. And with that, enjoy the very closing keynote, which is coming up soon at Pan IIT. Thank you, everybody.
Thank you, Aneesh. That was fabulous.